indication is unexplained infertility. In IVF, it is last, but in IUI, it is one. And that's why unexplained infertility, always you should go for IUI. I have got more than 170 patients of more than 3 IVF failure have conceived with IUI. 70% were of idiopathic infertility. So my carry-home message is that don't jump for IVF for unexplained infertility. Otherwise, you will well get a spontaneous pregnancy or pregnancy after IUI, after the IVF failure. So on unexplained infertility, superovulation with IUI has higher pregnancy rate than only superovulation, and that's why IUI should be added to the stimulation protocol. Ovulatory dysfunction, a case of hypogonadotropic hypogonadism. See here, there is a defect in ovulation. Correct the ovulation, rest of the things are done by the nature. I have got up till now 6 or 7 patients in my practice of hypogonadotropic hypogonadism, and all these patients have conceived with IUI. So here the HMG is used, and IUI will give excellent results in ovulatory dysfunction. Now, male infertility. Majority of the people, whenever the count is low, they just go for ICSI or IVF. But this is my landmark case that even after 7 IVF failure, the patient had come for IVF to me. But all my colleagues have done very well, and that's why I like to do something else than what they did. And I tried Professor Ishidori's regime, that is FSH-HCG combination were given to the patient, and the count improved to 22 million after 3 months, conceived by IUI in third cycle, and being the count more than 15 million, conception occurred, a spontaneous pregnancy after 2.5 years. So in a male infertility, please try to improve the count and convert an IVF or ICSI cycle into IUI cycle, or IUI into a natural conception. Then the pregnancy rates will be very good. Motile sperm count, ideally the sperm count should be between 0.8 and 5 million, but 1 million is considered as the normal post-was count for IUI. So the count should be at least 1 million post-was. Immunological infertility, always go for IUI. Superovulation for IUI is the first line of treatment in it. Endometriosis, mild to moderate, you go for IUI. Single tube, failed AID, HIV positive male and HIV negative female, go for IUI. Frozen semen and donor semen sample. I have already discussed the tube which is open on that side. If the ovulation occurs, then you should do IUI. If the ovulation occurs on the opposite side, you should not do IUI because you will be blamed for the failure. HIV positive male, 3,000 cycles. There was no seroconversion in female or in the baby. Now, stimulation protocol is very important, and particularly with the PCO patient, then you go for a chronic low dose protocol, and this will give a very good pregnancy rate that the FSH straight away. All IUI cycle, you should try always with the gonadotropin, because the gonadotropin gives a better pregnancy rate, and time taken for pregnancy is also less. Low dose gonadotropin is cost effective, and this should always be combined with IUI to the patient. We have developed a scoring system by which, with the help of the color Doppler, we find out the score, and according to the score, we stimulate the patient so the failure rates or the cancellation of the cycle is not found, as well as you won't get OHSS in the patient. So, by according to the score for IUI or for IVF, you can have the number of units that should be given to the patients. The absolute pregnancy rate, why stimulation? Why you should stimulate with gonadotropin? Because with monofollicular development, the pregnancy rate is 8.4%, while that with the multifollicular 15%, and level of evidence is 1A. That is, try to get 2 to 3 or 4 follicles, your pregnancy rate will definitely improve. We have found letrozole plus gonadotropin a very good combination, because letrozole is given from grade 3 to 7, and by the time the FSH and LH starts decreasing, at that time, recombinant FSH or highly purified FSH is started from day 8, 75 units every day for 5 days. And when the follicle is mature, then you can give HCG and you can do IUI. That will improve the pregnancy rate. So all patients are poor responder, as well as for the PCO, you combine letrozole plus recombinant FSH or highly purified FSH. But if it is a normal responding patient, then straightway you can start with gonadotropin from day 5. Agonist, it is an established treatment for IVF, but it should never be done in IUI. No down regulation is done in IUI because it increases the complication, multiple pregnancy, and the cost. So that's why this is never welcome. GnRH antagonists are very useful, particularly in a thin, lean PCO patient where the LH level is high, and because in this patient the androgen levels are high. So when the size of the follicle is 14 millimeters, start antagonist till the day of HCG. And when you give it till the day of HCG, then if you give HCG and then do IUI, pregnancy rate will be very good. Now the another use of antagonist in IUI is then when there is single follicle, the pregnancy rate is low, but if there are multiple, it is high. That's why if one or two follicles are 11 or 12 millimeter and the dominant follicle is 16 to 18, wait for a day or two by giving antagonist to the patient so that it will, the 11 and 12 will reach to 14, 15. And then if you give HCG, do IUI, there are 2 to 3 follicles available for the conception, and that increases the pregnancy rate. So always wait for it. Now, triggering of ovulation is done by 250 recombinant or HCG highly purified 10,000. But when there are multiple follicles, always give leuprolide acetate 2 milligram or decapeptyl can be given as 2 milligram or two ampoules can be given at that time. So the GnRH agonist will not cause OHSS. Only HCG can cause OHSS, and that's why whenever you are in doubt, when the multiple follicles are there, then always use GnRH agonist trigger. Now, whenever you use GnRH agonist trigger, the judicious luteal support is required. The 400 milligram 3 times a day micronized vaginal progesterone is given. Normally, cabergoline is not required, but if you are afraid of OHSS, then cabergoline can be given if you have given HCG to the patient. If you have given agonist trigger to the patient, then normally the OHSS does not occur. But suppose by chance you have given HCG to the patient and you have done IUI, then start cabergoline from the day of HCG for about 7 to 8 days, and that will decrease the incidence of OHSS. Now, because you have given GnRH agonist trigger, the E2 estradiol valeriate 2 milligram 3 times a day is indicated. Otherwise, estradiol valeriate is not indicated unless you have given agonist trigger. So that is indicated only with the agonist trigger. With HCG trigger, E2 is not required for the patient. Monitoring is done with the help of the color Doppler. At least you should have 3/4 of vascularity, and RI should be between 0.5, 0.4 to 0.5, and PSV should be 10. If these are the parameters of color Doppler, and if you give HCG, your pregnancy rate will be very high. Those who are having 3D can find out the cumulus also, can do the volume and measure the VI and FI values also. Same way for endometrium, triple line endometrium with vascularity in zone 3 and 4 will give you excellent results. And that's why to get excellent results, minimum requirement is the color Doppler. If color Doppler is that will pinpoint exactly when the HCG is to be given and the pregnancy rate will be very high. That means if higher the PSV, the follicle is closer to rupture, particularly in which patient you should go for double IUI. When the PSV is high, the follicle is likely to rupture earlier. And in these cases, we always do double IUI when the PSV is more than 15 to 20. Then you do double IUI. One is after 12 hours and second is conventional after 34 to 36 hours. So that gives a very good pregnancy rate by double IUI. So whenever the PSV of the follicle is high, you do double IUI. Now, how many IUIs? There are limited studies where 9 cycles are attempted and 6 cycles, the pregnancy rate are 30% and 9 cycle 41%. These are the rates with clomiphene and these are the rates without using the color Doppler. But if you use the gonadotropin and if you use color Doppler, then the pregnancy rates can be still much more improved. If the time is not an issue, then the 9 cycles can be offered if the age of the patient is below 35 years. So if you go to any IVF conference, you always listen that 2 or 3 IUIs are enough. And even if it is done with clomiphene or the letrozole, then it is considered as an IUI failure. But I told you that it is the personal failure. You should have the gonadotropin with color Doppler if IUI is done. And if the patient has not conceived, then and then only it is IUI failure. 2 cycles of IUI before 38 to 39 years, and 1 cycle if the age of the patient is more than 40 years. So the absolute minimum cycle should be 3, preferably 6 cycles. And if time is not an issue and if the age of the patient is less than 35, maximum 9 cycles should be offered. Now, this is very important. This is documented in so many papers that minimum, preferably 6 cycles should be tried. And I told you that if you start with gonadotropin, and if you use the color Doppler, then the pregnancy rates are very high. even National Institute of Health Care, all have said that the 6 cycle should be tried for the patient. Now, in UK, the parliament passed a law that only expected line of treatment for 2 years, no IUI, and straightaway IVF should be done to the patient. But only 4% of the gynecologists accepted this, 96% of the gynecologists favored IUI because there is a superiority of IUI above no treatment has been proved, and IVF is not regarded as a first line of treatment. So that's why that was withdrawn, and now the IUI is always tried before taking the patient for IVF.